Good afternoon, everyone. It's nice to see you. This is actually my first Alex TLC meeting. It's been a really wonderful weekend. I appreciate the invitation to speak about what's actually one of my favorite topics, women with ALD. So I'm going to be talking about how we can monitor the myeloneuropathy symptoms sort of from a clinical perspective, but also throwing in some research there and sort of talk about sort of over the next 2 to 3 years, big picture in terms of what are our goals for trying to get women into trials. So let's see, and so for a little more background, again, I'm at the, if you didn't hear when you came in, I'm at the Kennedy Krieger Institute Moser Center for Leukodystrophies. I'm a neurologist on the faculty there. I do about 80% of my time, though, is focused on clinical research. So mostly natural history and leukodystrophies, and I do a lot of work with wearable technology and trying to sort of get these detailed clinical outcome assessments in clinic, home, wherever we can get them, at conferences, just so we can kind of get these numbers we need in rare disease. So I don't have to tell anybody in this room, treatments are really desperately needed for women with ALD and actually really for men as well, for the myeloneuropathy still. So one of the challenges with this, of course, is that AMN can be very heterogeneous. By that I mean, this is in terms of symptom profile that people experience, especially over time. Age of onset varies, and then the progression rate, with some having an experience of pretty fast changing of their symptoms and some very slow. So we sort of have to capture the experience of all these experiences. So, adults with pathogenic variants in the ABCD1 gene are affected. We know this is essentially all males with a spinal cord form, and then recent estimates from several large cohort studies show at least 90% of females by the age of 60 will have the spinal cord symptoms. So it's a progressive myelopathy, and I'll talk about what that means. And then there's also the peripheral nervous system involved with neuropathy. So the major problems arising from that are with walking imbalance, bowel and bladder function, fatigue, pain, and this can be due to lots of different sources. One of the more direct sources is neuropathic, from, so it'll be like a numbness, tingling, pins and needles sensation in the legs or feet, and then a number of psychosocial concerns. And so related to these symptoms, especially the fact that they accumulate over time, many people also experience pretty big impacts on quality of life, and I'll go into those details in the next slides. So again, there's a major need for FDA-approved therapies for adult ALD. Certainly the field is promising in terms of what's available now for boys with cerebral ALD, having multiple options, but to at least prevent progression of, or to halt progression of cerebral disease, but sort of more work for the larger population. So, mm-hmm.
Just finished.
Oh.
So you were just going to come through.
Oh, sure, yeah. Mm-hmm. Come on in. Hopefully they can find a spot. Thanks. So it's really, critical to understand the current symptom burden and unmet needs, specifically for women with ALD, and to keep going with our efforts across centers to capture clinical outcomes that are sensitive to change in a short period of time and meaningful to patients. So just for to kind of get everybody on the same page, this recently published figure, this is actually from the Leipzig Leukodystrophy Center. It's about 130 women captured here with ALD. This sort of shows the prevalence of symptoms in women according to age. So you can see on the far left, the 18 to 29 age group, less than 10% of women, under 30 are symptomatic. By the 30s, this increases to about a third, and then there's this sort of dramatic shift. So by age 40 to 59, this is now about 80% of women that report symptoms. And then over the age of 60, a little over 90%. If you're surprised by these numbers, really we've gotten much better with the scientific literature over time. And just hearing these concerns, hearing them from a wider range of women, I think is certainly with more widespread newborn screening and genetic testing, women are sort of presenting earlier, even asymptomatically, so we are able to kind of capture that change better. Okay, so in terms of the major symptom categories experienced by women, there are three. So most prominent, gait and balance, followed really closely by bowel and bladder, and then sensory and pain. So I'm going to go into those a little bit better, in more detail. So at the top, the common gait problems are things like stiffness in the legs, having imbalance, some stumbling or falling, and weakness. And sort of early on, this affects participation in sports, dance, it might be as subtle as that, but then running and walking, of course. So the starts, about 2/3 of women will have some leg symptoms when they're in that youngest age category, but by over age 60, it's closer to 80, 90%. So super common, and I think kind of what I want to pay attention to is the fact that this is a problem that sort of grows over time. A lot of people want to know, in my clinic about walking aids, and when that might be something that's necessary or helpful to optimize mobility. And so from here we see that that sort of increases over time. So by age over 60, about 2/3 of women require some form of walking aid. But that increases from about 10% in that earliest age group, 25%, so it sort of gradually increases. And then it's about 10% or so of women that require moving mostly in the wheelchair over age 60. In terms of bowel and bladder dysfunction, I find this interesting. So even in women that don't have many walking symptoms or leg symptoms, bowel and bladder dysfunction is often present from an early age, and something I hope that people are talking to their clinicians about, because there are a number of good medications out there to help. But this basically, prevalence of bowel and bladder dysfunction stays around 80%, 80 to 90% throughout the lifetime in this cohort. Most of the time this starts out as more intermittent things, or things that are manageable, urinary hesitancy or urgency, sort of occasional breakthrough incontinence. Thankfully, permanent incontinence is relatively less common, so about 20 to 25%. Over the age span. And then for sensory and pain concerns, this is also, these are problems present early and they stay relatively stable, about 70, 80%. Thankfully, having permanent sensory loss or the sensation that legs are completely numb is very rare. Okay, so in terms of quality of life, how do all these symptoms affect what people feel day to day? And so looking at this health-related quality of life survey, we can see, so on that, symptomatic women are in one column, asymptomatic in the other. And so across all categories, physical functioning, pain, general health, sort of energy or vitality, social functioning, emotional and mental health, there are significant differences in how people rate their quality of life if they have symptoms versus no symptoms. And so the biggest difference category is in physical functioning. And unfortunately, mental health, it's different, but not very different, with both groups sort of reporting low or more concerns with mental health. So delving into this really important category more, 70% of women, so they were asked about depression symptoms in the prior 2 weeks. 70% of symptomatic women had some form of depression that was mostly mild, but some moderate and severe. And then 42% of asymptomatic women had some depression symptoms in the prior 2 weeks. Again, that might be surprising, but I think, sort of thinking about conversations I've had in clinic, one reason for this might be worry about disease progression, when that's going to start. Obviously, women are also, with ALD being X-linked, affected women can be in a really tough position as well. Having the responsibility to care for family, caring for sons, of course, that might be affected for fathers, and as well as, thinking about their own health concerns. So this is just a flag that we need to be paying attention to and talking about. And then suicidality was also asked about, any having thoughts of self-harm or suicidal ideation. and 15% of symptomatic women reported that in the prior week, almost 10% of asymptomatic women. In terms of pain, also very common. So symptomatic women, about 75% experienced chronic pain versus 28% of asymptomatic women. 80% of symptomatic women consider themselves to be poor sleepers versus about 56% of asymptomatic women. And one thing we know contributes to this is restless leg syndrome symptoms. So this sort of, more than spasticity or spasms, this sort of like restless need for the legs to move. So that's super common. And one piece of good news, if you weren't aware, there is a study right now in Amsterdam and at Boston at Mass General using pramipexole. So it's for Parkinson's disease and moderate to severe restless leg symptoms. It's FDA approved for that purpose, but there's a dedicated study to see if it helps RLS symptoms in ALD women. And so we should have some data on that in the next 1 to 2 years. And then sexual dysfunction, finally, is the last category. Again, we don't talk about a lot, but about 40% of symptomatic women experience this, and almost 20% of asymptomatic women. Okay, so I just want to switch gears a little bit for the next part of this talk about monitoring the spinal cord disease and ALD, how we do this accurately. I've already explained from the patient perspective why this is so important. From a pharmaceutical trials perspective, right now they want to know what outcome measures that we need to go after that might change in a short amount of time, especially for this variable condition. So right now, we have established clinical scales such as the EDSS, Expanded Disability Status Scale. I know others have talked about that today. So scales like this are really good at assessing somebody's function or their disability at a point in time, but unfortunately they don't change very quickly, and it's only an 11-point scale. So it would require really either hundreds of patients or looking over many years to see change there. So we essentially need, better quantitative measures, and again, that are linked back to some clinical meaning for patients. So one focus that we've had at Kennedy Krieger and with international partners is trying to capture more information about what's happening with the walking and balance with wearable sensors. So again, these are flexible because they can be done in the clinic or shipped home. It's actually pretty user-friendly patients learn how to set this up at home all the time, and we kind of easily cross-train staff at international sites. It sort of avoids the necessity to come into clinic to have this done. We send it home, so then we can get more frequent data points. And so up to every 6 months, we're sending these to people's homes. And then there's still a lot of support. So we basically set up a telehealth or a teleresearch visit, that's real time with an appointment time, and we do remote takeover of the screen and sort of run everything so that it's easy from the patient perspective. Okay, so we chose the system. I'm going to refer to them as the Opals. They look sort of like a Fitbit, and so these are accelerometers, and we put them on the feet and the waist to do the walking and balance tests. They have, I won't go into too much detail, but a long history looking at outcomes for other neurologic conditions in adults like Parkinson's disease, MS. So it's new, but not too new, thankfully. So I just want to show a little data from this ongoing cohort that we have of about 120 patients at Kennedy Krieger in Amsterdam. And if you can see in terms of the age and EDSS, so the women are in orange, the men are in blue. I'm going to show data for both. And it's pretty typical in that most of the women participating are over age 40 when most of them have symptoms. For men, it's a bit of a split with younger men having lower scores, or EDSS scores, probably because they're presenting for their cerebral disease screens but don't have many symptoms yet, and then older men who have had the disease for a while. Okay, so in terms of the balance testing, this is from the Opal sensor on the waist, And I'm just going to focus on sway conditions with the feet apart and eyes open, and then the feet apart, eyes closed. As you might know, closing the eyes makes it really difficult to maintain balance. So that really challenges the dorsal column dysfunction in the spinal cord. So first we looked at what is the relationship of sway with the EDSS disability score, since this is really established score based on the neuro exam. And so basically RMS sway is correlated with the EDSS. So basically the higher the EDSS or the disability score is, the more sway we see. So there's a really tight relationship there for the males, and both the eyes closed, actually more so in the eyes closed and the eyes open condition, as we would expect. And we see that same difference for the women as well. And then we looked at again, a walking device, is sort of a really important threshold that people sometimes get to. They didn't use the walking device while doing the standing test, but they just used the walking devices for walking in the community. And we did see a pretty clear difference in that there is a higher, so in the group of people that need a walking device, sway is much higher, and that was the same both for men and for women, looking at several different variables of sway. And then for walking tests, we used two tests, the 6-minute walk test, which is, fast-paced, really an endurance test. Honestly, we see that in clinic, a lot of times people are too fatigued, especially at the end of a long day, to do it. So then we also, kind of as a backup, have this 2-minute walk test, which is at your own pace. So we make sure as many people as possible can walk. That's also the test we can realistically do at home, because you need too long of a walkway in most homes for the 6-minute test. So I'll just show a little bit of the data from that. So essentially, we see for the men with a 6-minute walk test that the higher the EDSS, your EDSS score, the lower you walk. That's sort of a very clear relationship. For men, on the U.S. side, we basically are still collecting 2-minute walk test data. There doesn't seem to be a great relationship there. However, for the women, we do have enough women who've been doing this walking test to show that there's a significant relationship of the gait speed with the EDSS, and this is both in the 2-minute and the 6-minute walk test. So it's encouraging that we should keep doing this at home. The toe-off angle is another way to look at this. So I didn't focus on it too much, but a lot of people will complain of, tripping, stumbling, certainly having falls. A lot of this is related to angle of the foot. So there might be spasticity, weakness, with the dorsal column dysfunction, there's trouble sort of understanding exactly where your feet are in space. So there's lots of reasons why the angle of the toes might be different in AMN. And so we see that looking at the toe-off angle degree, that there is a strong relationship of this variable with the EDSS score. So basically, a more flat foot position is more abnormal, and we saw that with a smaller angle or flatter foot position, that there was a higher that was correlated with higher EDSS scores for both men and women. And then finally, what does this look like over time? So we're just about at the point where we can fully analyze this with the wearables. It's just taken a while to catch up. But we do have a little bit older data from the Lorenzo's oil trial, actually, that one of our research physical therapists, Jennifer Keller, has done. And so she's looked with an in-ground force plate in the motion lab at what is at some of the sway variables there. And so you can kind of see that in both eyes open, feet apart, and eyes closed, feet apart conditions, the numbers aren't the same for men and women, but they both do change for that whole group over 2 years. So this is we're in a phase of kind of moving beyond the 6-minute walk test and thinking about sway as a feasible measure to use for trials for both sexes. And then looking at the walking test, men did worsen with their 6-minute walk test endurance, but women didn't. So it really might not be sensitive enough for women. Okay. And then sort of the final data slide, which I think is really encouraging, it's just very early information, is investigating if exercise might actually improve sway and quality of life in women with ALD. It's a question, we talk about it all the time in clinic, if physical therapy really makes a difference, if exercise really makes a difference, if it can change the disease course. And so again, Jen Keller, our research scientist and PT at Kennedy, has started the study. I'm showing data for 6 women with ALD. And so essentially this is a home-based, remote 8-week training program. It's about 18 hours of commitment. And she does either progressive balance training or Tai Chi. And then separately, people can do a hip strength training program because we know the hip flexors especially are weak in ALD. So this was a group of actually all women age 53 to 72 with all across the board with functional disability scores. So it was very inclusive from that perspective. And so this wasn't perfect, but what we did see is that people who underwent Tai Chi or hip strength training improved in at least one of the sway variables, across the board. And you can kind of see at the top of that table that the women who had who had the mildest disability actually did improve in several different measures of sway. So that was encouraging. And on the other hand, for the women who did have a higher disability score, so using a cane or bilateral support, what did improve was their their self-reported quality of life. So how they felt about their mobility and how they felt actually about their sleep quality did improve. Beyond that, it looked like the Tai Chi program especially helped with how people perceive their quality of life with movement and sleep. And then finally, you can kind of see, and this is in the bottom table, that just about everybody improved on the 5-time sit to stand test. If you've ever done it, it's kind of tough, but you cross your arms and you are in a chair and you sit and stand repeatedly. And so even just 8 weeks of exercise shaves the time off of that. So really encouraging, and we're continuing that study. This is the final slide. This could have been easily an hour talk because there's a lot of work to do, but essentially we just have to keep the collaborative efforts up to determine these clinically meaningful outcomes and trial endpoints. We just don't have enough per center, so most of all the recent studies are joint, and there's a lot of, people are very open to that. So I think also exploring more similarities and differences in the experiences of men and women is critical. Really, I think the main goal is to make sure women are included in all of this work. And then in terms of, there's interesting work happening with monitoring and prognostic biomarkers. So you might have heard of lyso-PC, or C26 lyso-PC in the context of the newborn screen. It's a lipid molecule that's like it's more sensitive than very long chain fatty acids and distinguishing ALD diagnosis, but it also might have some use in understanding, and predicting disease course, or helping us distinguish more mild and severe forms of AMN. And so we're really trying to gather that data for women as well as men equally across sites. And then we can also do more publishing in terms of evidence-based recommendations for PT, targeted exercise, and other lifestyle interventions. I can tell you that in the next year, there's more papers expected on that, from groups in Germany, from Kennedy Krieger, from MGH, so hopefully a good update next year. As I mentioned, there's the restless legs syndrome treatment study right now at MGH and AMC. And then there's also, I don't have a lot of details on this, but you should know that there is a trial of dimethyl fumarate. It's an oral medication for MS that's getting started for both men and women with AMN symptoms in Spain. So I believe that they're actively enrolling. So it's basically the outlook is bright, and I think we just have to keep getting women involved in natural history and sort of keep making the argument that they deserve the same access to trials as men do. So that's, I think, pretty much what I have time for. Thank you.
Are there any questions?
Just thank you for that. That was really, really useful and interesting. Thank
Great.
you so much. I just noticed on that last slide it did say something about revisiting adrenal insufficiency, and I just wondered if there was evidence of that being higher in women, and also was it being overlooked because women were possibly seen as in where they need to be, but they're on the low end and therefore weren't getting the treatment that they needed?
Yeah, so right now, I think it's about, like, it depends on the paper that you look at, but maybe at least 10% of women with AMN have adrenal insufficiency. So we know it's not non-existent. Our practice at Kennedy is for every new woman who comes to the clinic to at least get a baseline, all the same, labs that we would get for men from, endocrine labs. Obviously act on that if there are any abnormalities, and then if there are any particular complaints that sound like they could be AI related, to just have a low threshold to test again. But I think sort of like we're over time understanding that a greater proportion of women eventually have myeloneuropathy symptoms. It could be the same like with AI. And then in terms of cerebral disease, we know it's like exceedingly rare in women, but we're trying to figure out. But actually, so this addresses AI and cerebral disease for women. Are there any risk factors that place some women at higher risk? So, for instance, looking at X activation, I think that might have been mentioned at least one time today, right? So this phenomenon that in the cells of our body, sometimes it'll be about 50-50 where you have the unaffected X and the affected X, but some women have high skewing towards the mutant, the pathogenic variant, right? And so in some cases, they can look a little bit more like the men, possibly a faster progression of disease. So this is why the biomarker studies and things are important, and just to make sure we're capturing all this information so we can see, are there women who are more at risk, or are there women that we need to be screening more frequently for these problems? Yeah, hope that answers it. You're welcome.
Any other? Yeah. I'll go here first, and I'll make more.
Okay. Sorry, I'll just be quick. Just a couple quick questions.
Yeah, of course.
The hip strength training, can that be made available to us? Will we be able to see that? Just as I know, I went to ALD Connect last year, and I remember them saying a lot about how that could be a preventative measure, for example. So can we see that? And also, just with regards to fatigue and mental health, something I've always struggled with, but I don't know if that's because there's something to do with AMN that means I've got a chemical, it causes it chemically, or if it's to do with situational, being affected by the disease, having family affected by the disease, is that causing it? So I wondered what the link was, which is causing which in those cases.
Yeah, really both good questions. So in terms of for the exercise program, it is a remote study, but we still have trouble with our IRB regulatory for actually trying to do the study itself outside of the U.S. So the best situation would be to find partners. So this is kind of what we've done for the natural history is partner with Amsterdam, for instance, and they essentially write the same protocol, right? The same research protocol, but they get it approved by their IRB, and then we do it in parallel. So that might be one option. If there are any interested researchers in the UK, we're more than happy to share what we have, to share methods and protocols. And then the other thing is, I don't think it's really proprietary, so it's like a progressive strength training program that probably a lot of PTs would be familiar with or could implement just on a personal basis. So I'm afraid of now Jen Keller is going to get lots of contacts, because I think her information is there, on the ALD Connect website and such. But I'm sure she could, if you have a PT or somebody who works with you that you would want to share that information, then I'm sure she would be open to that. Yeah. And then, sorry for your next question. Yeah, it's so hard to tease apart in time. It's certainly with any chronic neurologic condition, we see that sometimes depression levels and mental health concerns are higher. What I forgot to tell you was that about, looking across the UK, the US, other European countries, it's about 10 to 20% of people just in the general population or women that have depression. So we know those levels are higher even when people don't have symptoms. And I think it's, like you said, it's a number of the things that you mentioned that could factor into that. I really do think there's a lot of, I've heard the quote from somebody before, ALD can be a destroyer of families. It can really make things very disruptive because with it being X-linked, there's just, multiple people involved, and you're worrying about yourself, but you're often worrying about others. So I feel like that's just really compounds things. In terms of there being some white matter change or some change related to very long chain fatty acid effects, I don't think there's like a direct link, and really what we understand is it does seem like the disease is pretty limited to the spinal cord. So it's most likely these various psychosocial factors rather than a direct chemical or brain effect. Yeah.
What about fatigue, sorry? Is that something that's caused by the adrenal insufficiency? Or?
Yeah. So again, I think in terms of any adrenal insufficiency that reaches the clinical threshold, we don't usually see it. I mean, I have a low threshold to test for it if women have fatigue complaints, but often it looks normal, and not just the cortisol, but the ACTH, or like the precursor hormone that sometimes, when you start to see that creeping up, sometimes it means there's a signal of problem, even if the cortisol output looks fine. So I tend to look at both of those things and usually don't see a relationship. Yeah, so it's one of those things we're just still trying to understand exactly where it comes from. Yeah. Mm-hmm. Yeah, you're welcome.
2 questions. Firstly, the dimethyl fumarate, the trial, what outcomes are you hoping for in that? What changes might it be expected to make?
You mean with a trial, you said? Mm-hmm. Yeah, so, I mean, I think there's not been as much of a focus on this, but I think at least as secondary. So for clinical trials, you're going to have a primary outcome, and then you can have lots of secondary outcomes. And so just to make sure everybody's on the same page. And so the secondary, it can even be neuroimaging markers, right, to see if you see improvement in white matter tracts or tissue volume in the spinal cord. Like, that's something I personally would love to have included. I would love to look at things like the lyso-PC levels and maybe some other biochemistry as a secondary outcome. Clinically, we need to not forget about bowel and bladder symptoms, because as I mentioned, it seems like that is such a universal thing, and it's across age groups for women and also, of course, for men. I have definitely never seen bowel and bladder dysfunction scores as a primary outcome, but we should be looking at it. So some of you might know for the liraglutide study, Advance in Men, that primary outcome of 6-minute walk test distance was not met. So we do have to move on from that. And we continue actually to have conversations with Minarex. Thankfully, they're still interested in women. They're in the middle of a 2-year natural history study in France, actually, and I don't think they've given up on that question, but they keep asking us, the researchers, what's the outcome? So we're really focusing on sway. We're trying to do more publication about that, linking sway to quality of life, because we know that affects, again, things like need for walking aids, or is this related to that? And probably the balance has a bigger influence on walking than we're realizing too. And it did actually look like in the secondary data analysis from that advanced trial that there was some impact of sway. So I think we have lots of reasons to kind of focus on that.
Okay, so the sway test is in fact a type of balance test, is that correct? Yeah, okay, and can I just, before I go, the dimethyl fumarate, you mentioned white matter changes. Are we talking about remyelination with that?
Sorry, I didn't hear the first, I didn't hear what you said before changes. What kind of changes?
So white matter changes
yeah.
on the MRI scan, are we talking about remyelination?
That's a good question. I mean, I think right now it's hard to know what the effect of various treatments will be. Like for liraglutide, I don't think we have any idea, nor unfortunately, like I can say for the Calyx study, because we're a site at Kennedy, we're not doing spinal cord imaging. The hope would be that, but I think what we would at least want to expect is just like to halt progression of clinical symptoms that we would also see that reflected in the spinal cord. So what I would hope is that it would change the sort of the linear, you might see the slope changes in terms of the volume loss. So what we can see is like in the cervical spinal cord, we know that volume tends to get smaller over time. And so I would hope that then the volume would either get smaller but at a slower rate, or that we would see that halt. And then we would have to kind of look at more specifics of with more advanced white matter techniques in the spinal cord to see why that's happening. Is it remyelination, or is it just preservation of what's there? Yeah. Mm-hmm.
With AMN in ladies, does the linear decline lessen as you get older, or does it just carry on?
That's a great question, because right now, because we have relatively small numbers of people, not because we've had really enthusiastic participation of our women, but this is still really rare disease. So it gets hard when you start trying to see a statistically significant relationship. If you're breaking women up into age groups, it's hard to see. I think it's just based on that data that I showed you in the beginning, where more women are having more walking trouble, more women are depending on using a device or maybe a wheelchair. Probably it does speed up with age. We just don't have enough information to say that for sure. Does that make sense?
Sorry, did you say speed up with age?
Yeah. Decline. I probably went this direction because I was thinking of declining or worsening, but we just don't know.
It never plateaus? It's never been seen to plateau at any stage?
That's what we're really looking at. So I don't think I can go back to my presentation, but the paper I showed looking at the force plate sway and walking changes, that was from, I think it was published in 2022 in Journal of Inherited Metabolic Disease. But so, you can certainly look at it, but the point I wanted to make is that not everybody's lines are the same, right? So some people because she had to baseline 1 year and 2. So some showed a pretty linear decrease the full time.
This one?
Yeah, actually, can you go 2 ahead? Thank you. So, that one. Yeah. So that might be hard to see from back there. And so the red lines are the women, the blue dotted lines are the men. So not just looking at the mean line, but you can see some people, increased pretty fast over that time, but there's certainly a lot in the middle that kind of stayed stable, right? And so, again, when we're talking about trials and outcome measures, we're thinking about what are the changes for the group as a whole. Obviously, you care about the individual, I care as a clinician about the individual. We're trying to figure out, considering all of these people and the variability and the age differences, what's a high signal that could apply to the most people. Does that make sense?
Yeah.
So,
sorry, just one last question was I think it was EDSS. What does that stand for? Oh,
EDSS? Yeah, sorry. It's the Expanded Disability Status Scale. It's essentially an exam a doctor would do, looking at your strength testing, vibration testing. They consider things like eyesight. They look at sway just in the clinic, and they also will ask about how far you can walk and if you need walking devices. And so all of that kind of goes into an algorithm to say what your EDSS score is from 0 to 11. Yep. Thank you. You're welcome.
Thank you. I just have a question about the fatigue symptom. Mm-hmm. I understand you have a bad night's sleep for whatever reason, you're tired in the morning, or if you have a hard day's work, you're tired. I'm just wondering, with AMN, is there something going on with us neurologically that's tiring us or harder for us to do? My physio says it's just harder for you to do this, and pushes it aside. I'm just wondering, is there a neurological element to being tired?
Yeah, that's a good question, and I think that another young lady had asked a similar question. It's difficult to say. So again, I think when you can see white matter changes in the brain, in some cases that you can think about a link with fatigue from there, but we just don't. At least right now, our MRI, we don't have a capability to detect those changes in women. And again, ruling out adrenal insufficiency, or at least at a clinical threshold, doesn't seem to be contributing to that. MS, or multiple sclerosis is another I mean, I feel like there's a lot of overlap, especially because they tend to have a lot of white matter disease in the spinal cord. And fatigue is a big part of MS, and there are medications actually to try to improve that. Again, it's like a bit of a mystery in terms of why it happens, but it does seem like a phenomenon that happens. Based on my anecdotal experience, and again, seeing other neurologic conditions where there's spinal cord disease and progression over time, that's a factor. And so I think, in the last slide, I talked about symptomatic treatments and having more evidence-based treatments. I think one thing we can do is like super practical, like this restless leg syndrome study. If half of women with ALD have restless leg syndrome, then let's just do a trial where we see if that, for an approved treatment, to see if it significantly helps. For MS, there are approved treatments in the US. I think Nuvigil, Provigil, there are things that help improve fatigue. And so it might be smart to, on a systematic basis, see if those things help, even if we don't understand exactly why it's there. Yeah. You're welcome.
Okay, thank you so much. And
Thank you.